We are all very well aware of the coronavirus pandemic. As a dentist, we need to be even more focused on the setting and maintenance of extremely high standards for cross-infection control. Rubber dam, along with all the other protocols for hygiene and disinfection, offers clear safety benefits for both the clinical team and patients alike. Rubber dam was introduced in 1864 by Stanford C. Barnum. It separates the operating field by isolating one or more teeth from the oral environment. A rubber dam is effective in improving the quality of clinical restorative dentistry by ensuring appropriate dryness of the teeth. So, what are the advantages of using rubber dam? Using a rubber dam, we can perform procedures such as tooth preparation, caries removal, and insertion of restorative materials with ease. It might look like a hassle, but the time saved by operating in a clean field with good visibility is more than the time required to place a rubber dam. A rubber dam is recommended for the excavation of the deep caries lesion, as there is a risk of pulp exposure and exposed pulp can get contaminated due to saliva. The rubber dam controls moisture and also retracts the lips, cheeks, tongue, and gingival tissue. This gives us good access and visibility of the gingival aspects of tooth preparation. A dark colored rubber dam provides a non-reflective background, which is in contrast to the operating site. Because of moisture control, rubber dam enhances the optimum physical properties of restorative materials. It protects the patient from aspirating or swallowing small instruments or debris associated with operative procedures. It also protects soft tissues and tongue from irritating or distasteful medicaments like etchant and astringents. The rubber dam retainer helps provide a moderate amount of mouth opening during the procedure. Quadrant restorative procedures are facilitated. This means all the dental treatment required in a quadrant is carried out in a single appointment. These are the advantages of the rubber dam, but there are some conditions where the use of the rubber dam is contraindicated, like when the tooth has not erupted sufficiently to support a retainer, some third molars, and severely malpositioned teeth where the retainer is difficult to place. Patients who can't breathe through the nose and if the patient has a latex allergy are also contraindicated. Rubber dam material is elastic and is available in 12.5 into 12.5 cm or 15 into 15 cm sheet size. The material is also available according to thickness, like thin, which is 0.15 mm, medium, which is 0.2 mm, heavy, which is 0.025 mm, and extra heavy, which is 0.3 mm. The thicker the dam, the more tissue retraction can be achieved. Thicker dams are also more resistant to tearing, but thinner dam material can pass through the tooth contact easily, which is useful in teeth with limited mobility and tight contacts. For everyday restorative therapy, the medium thickness is ideal, as it offers both good tear resistance and tissue retraction. Light and dark dam materials are available, and darker colors are generally preferred for contrast. The rubber dam material has a shiny side and a dull side. Because the dull side is less light reflective, it is generally placed facing the occlusal surface. It is a U-shaped metal instrument with small projections from the borders. This frame holds the dam material in place. Rubber dam clamp or retainer anchors the dam in place to the most posterior tooth to be isolated and also retracts gingival tissues. The retainer has 4 prongs. These are 4 pointed projections that rest on the tooth at its 4 line angles. This 4-point contact prevents rocking or tilting of the retainer. There are 2 jaws that hold the dam to the tooth, and these are connected by the circular bow. Wingless and winged retainers are available. The winged retainer has anterior and lateral wings. These wings are designed to provide extra retraction and also to hold the rubber dam in place before its actual placement on the tooth. Before placement of the retainer, the bow of the retainer is tied with dental floss, as this allows retrieval of the retainer if they are accidentally swallowed or aspirated by the patient. Retainers are available in various sizes and shapes. The rubber dam punch is a plier-like instrument in which one end has a rotating cutting table with holes of varying sizes, and another end has a tapered, sharp-pointed plunger. The rubber dam material is placed on the rotating disc and it is pressed against the plunger tip to get a proper hole. The size of the hole can be changed by rotating the disc. Most rubber dam punches have either 5 or 6 holes in the cutting table. It can be confusing for a beginner to decide which one to use. The smaller holes are used for the incisors, canines and premolars, and the larger holes are for the molars. The largest hole generally is reserved for the posterior anchor tooth. The rubber dam retainer forceps are used for placement and removal of retainer from the tooth. A napkin is placed under the rubber dam on the extraoral skin for patient comfort and to avoid direct contact of the napkin with the skin, and it soaks the saliva seeping at the corner of the mouth. Water-soluble lubricants are applied to the punched hole in the rubber dam material to ensure the material passes through the proximal contact easily. This was about the instruments required for the placement of the rubber dam. Now, let's see how a rubber dam is placed. First, the proximal contacts are examined by passing waxed floss through the contact. This provides lubrication and removes debris. Then, the dam material is punched using the template to guide the position of the tooth. After that, the dam is lubricated with the water-soluble lubricant using a cotton roll or gloved fingertip. A retainer is selected based on the size and shape of the tooth. First of all, the retainer is tied with the floss and placed on the tooth to verify its stability. If the retainer is poorly fitted, it is removed either for adjustment or for selection of a different size. If the retainer is stable, the forceps is removed gently. Now we need to place the rubber dam. With help of our forefingers, the anchor hole of the dam is stretched over the retainer and then under the retainer jaws. The lip of the hole must pass completely under the retainer jaws. The rubber dam material should be gathered in one hand and the napkin is placed on the skin. After placement of the napkin, the dam material is unfolded and attached to the metal projections of the frame. We can place the retainer and dam simultaneously to reduce the risk of the retainer being swallowed, or the dam may be stretched over the anchor tooth before the retainer is placed. The advantage of this method is that it is not necessary to manipulate the dam over the retainer. Now, how to remove the rubber dam? Before removing the rubber dam, first rinse and suction to remove any debris. Stretch the dam facially, pulling the septal rubber away from gingival tissue and the tooth. Clip each septum with blunt-tipped scissors, freeing the dam from the interproximal spaces. Engage the retainer with the retainer forceps and remove the retainer. After the retainer is removed, remove the dam and frame simultaneously. Wipe the patient's lips with the napkin after the dam and frame are removed. Then, make the patient rinse with water and examine for dam material left in the interproximal area of the tooth. Let's recap what we learned. Studies have shown that for successful long-term bonding in restorative dental treatment, a surface free of contaminants such as crevicular fluid, saliva glycoproteins, and blood is necessary. The only way to achieve and maintain a clean restorative surface is with dental dam isolation. For everyday restorative therapy, a medium thickness dam is ideal as it offers both good tear resistance and tissue retraction. Even though it looks like a hassle when you have a number of patients waiting for you, if you follow a simple dam placement protocol for every procedure, it will help support successful long-term outcomes in restorative care. Clinicians should be able to achieve complete isolation in less than 3 minutes, eliminating the most common reason for not using a dental dam.